Good morning. Here we back again to the hematopoietic and lymphoid module pathology lectures. The last we will start with leukemia. What is the meaning of leukemia? When you hear about the leukemia, what is referred to? What jump in your mind? Why the people are fearful of this disease? Leukemia is cancer. It's the cancer that starts in the blood-forming cells in the bone marrow. The cancer that started in the factory that produce blood cells were in the bone marrow. When one of these cells changes and become leukemia cell, then it wouldn't be any longer to be matured the way that it should be grow and out of control. So it will proliferate to the level that wouldn't let it to be mature and functioning. So it divides to make new cells, which is in the way that are faster than normal. Leukemia. Leukemic cell at the same time don't die when they should. This lead or allow them to build up in the bone marrow, crowding out normal cells. So, at some point, the leukemic cell leave the bone marrow and spilling into the bloodstream. So this increase the number of the white blood cell in the blood. When there is leukemic cell in the blood, it can spread into any organ, such as in the liver and spleen, which lead to or development of the hepatosplenomegaly, to the lymphadenopathy, or to the central nervous system involvement, and it will prevent those the normal cells of this organ from functioning normally. Leukemia is different from other type of the cancer that arise or the start in the other organ, like in the lung and colon or breast, and then spread to the blood or to the bone marrow. The cancer that start elsewhere and then spread to the bone marrow are not leukemia. Leukemia is myeloid or lymphocytic, depending on which the bone marrow cell the cancer start in. So, myeloid neoplasms. What is the meaning of myeloid neoplasms? What include myeloid neoplasms? It include acute myeloid leukemia and chronic myeloid leukemia. What are the difference in between two types of leukemia? What is the classification of acute myeloid leukemia, or what are the types? Actually, there are from M0 to the M7. What each subtype of acute myeloid leukemia characterized by. So, all of these will be included in the next slide with the pictures that accompany each type of leukemia. Regarding chronic myeloid leukemia, what reminds you when chronic myeloid leukemia mentioned in front of you? Is it referred to or is it associated with certain chromosome that you always, when it's mentioned, you always correlate with this type of leukemia? Is it associated with Philadelphia chromosome? What is the Philadelphia chromosome? What type of translocation it mean by Philadelphia chromosome? Is a Philadelphia chromosome, when present or when exists in chronic myeloid leukemia, carry good prognosis or bad prognosis? All of these, including the clinical features, the karyotype, histochemicals, the differentiation or the type, the histochemical stains that are used to differentiate acute and chronic myeloid leukemia from the lymphoblastic leukemia will be included in this types or the set of slides. Myeloid neoplasms arise from the hematopoietic stem cell and typically give rise to the monoclonal proliferations that replace normal bone marrow cells. In acute myeloid leukemia, the neoplastic cells are blocked at some early stage of myeloid cell development. So the immature myeloid cell called blast, which can exhibit the evidence of granulocytic, erythroid, monocytic, megakaryocytic differentiation, and it accumulates in the bone marrow, replacing the normal elements and frequently circulate in the peripheral blood. The diagnosis and the classification of AML are based on the results of the morphologic, histochemical, immune phenotypic, and karyotypic studies. The classification of acute myeloid leukemia, according to French American British classification FAB, acute myeloid leukemia AML is divided into 8 categories MO, M0 to the M7. From MO to M3 depend upon the degree of the maturation. From M4 to M7 it depends on the lineage of the leukemic blast. MO or M0, minimally differentiated. Blast cell appeared minimally differentiated. That is really it is hard to differentiate the blast cells. M1, acute myeloid leukemia without maturation. M2, acute myeloid leukemia with mild or minimal maturation. M3, acute promyelocytic leukemia. M4, it is myelomonocytic leukemia. M5, acute monocytic leukemia. M6, acute erythroleukemia. And lastly, M7, it's acute megakaryocytic leukemia. Each one of them will be discussed and we will show that how it's differentiated from each other and what is the characteristic feature of each. At the same time, what is the karyotype, what is the histochemical differentiated molecular changes or molecular chromosomal abnormalities that is sometimes seen in each type. In next slide, it will be discussed. Clinical features. The disease affects older adults. It is not like acute lymphoblastic leukemia, which affect more and is more common and affect the younger age group, or it is affect the children. The median age about 50 years. However, it might affect the children, which constitute about 20% of childhood leukemia. Symptoms and signs are related to bone marrow failure. What does that mean? That means that this neoplastic cells or the cancer cell replaced the normal hematopoietic element. So this normal hematopoietic element replaced by the malignant blood cell. What will happen when the malignant blood cell replace the normal hematopoietic element? There would be the feature of anemia, weakness, pallor, low hemoglobin level. Patient having neutropenia because it replaces also the granulocytic element. The patient susceptible to the infection due to the neutropenia. Bleeding diathesis, patient predisposed to the bleeding tendency, purpura, geotic bleeding, hematuria, bleeding pergum, epistaxis, due to that thrombocytopenia. And there is renal impairment due to the hyperuricemia and gout. The other features or clinical features might be due to the infiltration of the organ. What does that mean? That means when there is infiltration of the malignant cell to the in the liver and the spleen, it will lead to the hypersplenomegaly, into the lymph node lymphadenopathy. So the patient might have hepatosplenomegaly, might have lymphadenopathy, might have brain involvement, other organ, any organ might be involved because the infiltration of the malignant cell into the bone marrow, which will lead to the bone pain and tenderness. AML represent as rarely. AML might be presented as discrete tissue mass. The tissue mass, but it is leukemia, acute myeloid leukemia. This is called granulocytic sarcoma. This is a common symptoms of leukemia. Systemic weight loss, fever, frequent infection because of the production of the factors or the cytokines from the malignant cells, which lead to the fever, weight loss, and loss of appetite, and fatigue, shortness of breath in the lung, muscular weakness and tiredness, joint pain, bone pain, spleen and liver enlargement, which lead to the dyspepsia, discomfort in the abdomen, lymphadenopathy, cervical lymphadenopathy, might be axillary lymphadenopathy or generalized lymphadenopathy. It's affect the whole lymph nodes groups in the body. Also, the patient might presented with a night sweating. Patient feel and that he has sweating during the night, bleeding tendency. Patient have easily bleed from his gum, sometimes sudden bleeding per nose, epistaxis, bruising in the skin, bluish patches, ecchymosis, petechial spot or hemorrhage in different part of the skin, which is not the site when the patient usually has trauma. This is a gum. This is most commonly in the acute monocytic leukemia, which is the common feature, gum hypertrophy. Look at the gum in this patient. There's hypertrophied, which is most commonly feature of acute monocytic leukemia. Now we are coming to the pathogenesis of the acute myeloid leukemia. Most of the acute myeloid leukemia harbor mutations in the gene encoding transcription factor, which is required for the normal myeloid cell differentiation. So, this mutation interferes with the differentiation of early myeloid cells, which lead to the accumulation of the myeloid precursors, which is the blast in the bone marrow. The most important translocation that is seen in acute myeloid leukemia is in the acute promyelocytic leukemia, which is a translocation between 15 and 17. This results in fusion of retinoic acid receptor alpha gene on a chromosome 17 and the PML gene on a chromosome 15. This translocation should be memorized. The chimeric gene produces a PML and retinoic acid receptor alpha fusion protein which block the myelodifferentiated at the promyelocytic stage. So it inhibits the function of the normal retinoic acid receptor. Therapeutically, what is the importance of knowing that the karyotype in patient with the leukemia is very important on the therapeutic point of the view? Because in such a case of acute promyelocytic leukemia, we can use all trans-retinoic acid analog to vitamin A. When it is used as a therapeutic option, it will overcome this block. So it will enhance the promyelocytic to be promyelocyte to be differentiated into the mature neutrophils, which thus treated this type of leukemia. This is an important example of highly effective therapy which is targeted at a tumor-specific molecular morphology. What would be seen in the patient with acute myeloid leukemia? In bone marrow examination, in AML myeloid blast make up more than 20 to 30% of the bone marrow cellularity. It is very high. 20% to 30% of the myeloblast in the bone marrow, it is very high because the maximum that should be seen in normal person is not more than 5%. Here we are coming to the 20 to 30%. The cellularity, myeloblast are precursor of granulocyte, which have delicate nuclear chromatin, 3 to 5 nucleoli, and fine azerophilic granules in the cytoplasm. There is distinctive red staining rod-like structure known as arrows may be seen in the myeloblast or in more differentiated cell. Cell like promyelocyte, they are particularly prevalent in acute promyelocytic leukemia. Arrows are found only in the neoplastic myeloblast and are thus helpful as a diagnostic clue when present. Arrows are seen in more maturation type of the AML. In other subtype, monoblast, erythroblast, megakaryocyte are predominate. This is a bone marrow, hypercellular bone marrow in patient with acute leukemia. This is very high. This bone marrow showing very high cellularity, more than normal more than normal bone marrow cellularity. This bone marrow smear showing involvement by the acute myeloid leukemia. Look at the cells. Look at the cells. If you look at this smear, which showing the acute myeloid leukemia, this is a group of myeloblast, large cells with the large nuclei, minimally differentiated. This cannot be differentiated whether it's a myeloid or a lymphoblastic leukemia. Therefore, it is very highly undifferentiated. It's type the M0, which is difficult to be differentiated. Look at the chromatin of the nucleus and look at these faint looking the nucleoli. These nucleoli mean this is a blast. This is a blast cell. However, it is really hard to be differentiated into the myeloid and lymphoblast in such a type of the bone marrow smear because of this type of the M1, which is minimally differentiated. But here we can recognize them as a blast because of the type of the cells, because of presence of the nucleoli in the nucleus of this blast cell. The number of in the peripheral blood film, the number of the leukemic cell in the peripheral blood is highly variable, being more than 100,000 cells per cubic millimeter, but in 50% of the patient being under 10,000 cells per cubic millimeter. Occasionally, the peripheral blood may not contain any blast, so this is called a leukemic leukemia. It is just we just see that there's a different type of the cells, but there is no blast from the granulocytic cells, but there is no blast. In such a case, we say that this is a leukemic leukemia. For this reason, the bone marrow examination is crucial and essential in order to exclude leukemia in patients with pancytopenia. Sometimes blood film is looking normal, or sometimes they're slight shifting to the left. Some of the immature cell which is seen in the peripheral blood, however, there is no blast cells are identified in the peripheral blood in such and with the of course clinical feature of the patient might have fever, lymphadenopathy, certain pancytopenia. The whole blood element are decreased. Pancytopenia, including anemia, thrombocytopenia, and leukopenia. In such a case, bone marrow examination is crucial in order to exclude leukemia or confirm the leukemia in patient with pancytopenia. Because of different responses to therapy, it is of great practical importance to distinguish ALL from the AML, acute lymphoblastic leukemia, from acute myeloid leukemia, because the therapeutic, from the therapeutic point of the view, it is different. Usually, the nuclei of the lymphoblast in Röntgen stain preparation have somehow coarse, more clumped chromatin, fewer nucleoli than myeloblast. And the cytoplasm of these lymphoblasts contain large aggregate of PAS, shift positive material. Myeloblast tend to have fine chromatin. The chromatin that present in the myeloblast is finer than the clumped chromatin that are found in lymphoblast. And the nucleoli in the myeloblast is more. It's about 3 to 5 nucleoli. And they contain more cytoplasm, contain fine eosinophilic granules, which are often peroxidase positive. Here it is PAS shift positive material, the large aggregates in the cytoplasm with smaller amount of the cytoplasm in the lymphoblast, less number of nucleoli. The chromatin of the nuclei is more clumped, while in myeloblast, fine chromatin, more finer than the lymphoblast, more nucleoli, about 3 to 5 nucleoli, and the cytoplasm is more in the myeloblast than lymphoblast, and it is contained fine eosinophilic granule, which is peroxidase positive. There is distinctive rod-like, which is present in the myeloblast. Rod-like structure called rod. Rod are present in the myeloblast. Rods are only found in neoplastic myeloblast, are not present in any other myelocyte, or it's only found in the neoplastic myeloblast. So it's very important when it is found to differentiate the cells from other types. This is a lymphoblast, a nuclei. Look at this is a lymphoblast and this is a myeloblast. Because at M0, it is difficult to differentiate that this is whether it is this myeloblast or lymphoblast. But we have certain criteria that we just discussed in order to differentiate. Here, look at the cytoplasm. It is a rim of cytoplasm, while here the cytoplasm is larger. With granules, here it is more granules than the granule in the lymphoblast. The chromatin here is more coarse, darker in color, while here is more fine chromatin. Even the number of nucleoli here, it is obvious nucleoli than the nucleoli in the lymphoblast. Myeloblast in acute myeloid leukemia. Look at here, fine chromatin of the nuclei. There is certain amount of the cytoplasm. This is when there is no granules, so this means more myeloblast, more in M0 and M1, minimally differentiated, more in nucleoli. This is nucleoli. This is a nucleoli, more prominent and obvious nucleoli. Myeloperoxidase, which is positive in patient with acute myeloblastic leukemia. This is also a myeloperoxidase stain. This is a myeloperoxidase stain positive in the myeloblast. This is a positive myeloperoxidase which is found in the myeloblast. While in the acute lymphoblastic leukemia, the lymphoblast, it is positive for periodic acid shift, which is here. This is a characteristic of the acute lymphoblastic leukemia because it is found in the lymphoblast. So we can differentiate between the two in very early stage of maturation, or in the leukemia of minimally maturation, or the leukemia that we cannot distinguish this type of leukemia, which is myeloid, from the lymphoblastic. We can do peroxidase stain and a periodic acid shift in order to differentiate. So it is positive PAS shift in the lymphoblast, while peroxidase positive in the acute myeloid leukemia. Lymphoblast is also periodic acid shift, which is this is a very characteristic feature of the cytoplasmic staining in the lymphoblast in patient with acute lymphoblastic leukemia. French American British class FAB classification of the acute myeloid leukemia is this. First, it is M0 or MO, minimally differentiated, so very hard to differentiate it. It's constituted about 2% to the 3% of the acute myeloid leukemia. In such a case, blast lack erode, because if it is present, the erode is present, it is not M0, because the erode is, we already differentiate that this is acute myeloid leukemia. The stain negative with the myeloperoxidase, so it is very minimal differentiated, positive with the myeloid associated antigen, which is CD13, 14, 15, 64, or CD117. This is the myeloid associated antigen that are positive in such a case of the minimally differentiated AML. M1, also without differentiation, which constitute about 20%. Some of the blasts, about 3%, are myeloperoxidase positive, some of them, and some of them may show erodes. It is very little maturation beyond myeloblast, very little, but it is more maturated, or could be identified more than the minimally differentiated. Here is the without maturation. We can't identify this, whether it is a lymphoblast or myeloblast. Some of them, about 3% out of 20% that are the total percentage of it, is myeloperoxidase positive, some of them showing erodes that could be differentiated. But generally, it is a very minimally differentiated AML, or without differentiation. In acute myeloid leukemia, here, the myeloblast with maturation M2, we found that it is the more nucleolus are found. This is a nucleolus, this is nucleolus, this is the nucleolus, and these are the faint looking in the nucleus, and the more cytoplasm. At the same time, there's erodes. This is make the examination and the differentiation is more easier to the hematopathologist, that it is showing that there's erode intracytoplasmic this erode structures that make it more, and render the slides are more easier and readily to be diagnosed as a acute myeloid. This is another microscopical view of myeloblast in M1. This is an M1, and this is an M2 acute myeloid leukemia. Actually, the differentiation between the two is not so much high. Sometimes some of you might ask that it is really difficult to be differentiated. Yes, it is difficult, but as a pathologist and hematopathologist, we have our pathological experience and subjective view that we can differentiate in between the two. Here there is no differentiation, that's just the blast cell found, while here there's this is actually there's some of the granulocytic series that could be seen. Of course, this is just a shot of the slide, one slide. We have to see the whole picture, and then we can give the proper diagnosis, the subtype of the acute myeloid leukemia. However, in the acute myeloid leukemia M2, there is maturation. That's mean there is we can see some series of the granulocytic series, not like the M1. We don't, there is very minimal maturation into other series of granulocytic lineage. And at the same time, this is more common, about 30 to 40 percent of the acute myeloid leukemia, and erodes are found in high percentage of the cells. Here in M2, acute myeloid leukemia with maturation, as we have seen, they constitute 30% to 40%. More than 20% of marrow are myeloblasts. Therefore, we say it is leukemia because should be the blast more than 20%. To say it is acute myeloid leukemia, to say it is leukemia, the blast should constitute more than 20%. The cell, but we can see later stage of granulocytic differentiation, as we have seen in a previous slide, which is look like neutrophil, but multi-lobed cell, but it is not fully maturated. Stain with the myeloperoxidase positive, showing roads which are specifically seen in the acute myeloid leukemia, and it is here associated with the translocation 821. M3 is more specific because it is called acute promyelocytic leukemia. It is constitute about 5 to 10% of acute myeloid leukemia, consisting of the abnormal or immature promyelocyte, which is this type of this type of the immature cells characterized by the cytoplasm are much abundant than the nucleus, than the previous myeloblast. Of course, the more abundant, more numerous rows can be seen, and also there is a granules can be seen in the promyelocytes, and it is associated specifically with the translocation of 15 and 17. With this, in this type of or subtype of the acute promyelocytic leukemia, it is associated with the high incidence of DIC. This is a promyelocytic leukemia. Look at rods, which is very large number of the rods in the cytoplasm, more cytoplasm, which is more granular in appearance. This is in the AML of M3. This is also a bone marrow aspirate in acute myeloid leukemia M3. We are seeing there is promyelocyte. This is a promyelocyte. There is abundant rods are seen and abundant cytoplasmic granules, and we can see there is the cytoplasm is really abundant than the cytoplasm that have seen in the M2. This is also promyelocyte. This is also promyelocyte. If you focus on the slide, you will see that this is different in the size of the cell. At the same time, there is, of course, there is nucleoli are seen. This is a nucleoli are also seen in the promyelocyte, but at the same time, there is rods and the granules and the cytoplasm is abundant. This is AML3. This is another picture showing promyelocytic leukemia M3. Promyeloblast. This is promyeloblast. All of these are promyeloblast. These are all, and of course there is also other granulocytic maturation can be seen. This is a metmyelocyte, and this is eosinophil, or the not fully maturated, but it's about to be fully maturated eosinophil with the with metamyelocyte. Here is a promyeloblast, and then these are but most of the cells here in this slide is the promyelocyte or promyeloblast with the it is M3 leukemia, in which there is abundant rods and fine cytoplasmic granules. Another M3, and this is M4. This is M3 as we discussed in the previous slide, and this is M4, in which there is myelomonocytic leukemia, in which this is a mono and myelocyte. This is a myelocyte. This is also this is a mono. Myelomonocyte. This is monocyte. This is a myelomonocytic leukemia, in which two population of the cells are seen in the M4. Acute myelomonocytic leukemia, which constitute about 15 to 20% myelocytes, show monocytic differentiation. Cell in this case of the myelomonocytic leukemia, it is stain positive with lysosomal non-specific esterase, which this is very important histologically to be differentiated from the other type of the leukemia. Occasional errors can be seen, and it is associated with the inverted chromosome 6. M5 monocytic leukemia. It's acute monocytic leukemia. It is represent about 10% of the AML, composed of monoblast and immature monocyte. Errors are absent here. There is no monocyte. In the myelomonocyte, because there is myelocyte, it is associated with occasional errors. Here there is no errors because this is a monocytic leukemia, but it is stained with a lysosomal non-specific esterase, and it is negative with myeloperoxidase, which is positive where in the myeloid series. It is stained with the CD68. In this slide, we see that there's a myelomonocytic leukemia M4, in which there is two population of the cells are predominantly seen as myelo and monocyte, immature myelocyte and monocyte here, so showing the monocyte, immature monocyte. This type of the leukemia is positive with the stain, positive with the non-esterase lysosomal enzymes. Some errors are seen in the myeloid series, while in the monocytic leukemia M5, the errors are not seen. Myeloperoxidase are negative in the M5 because it is the monocytic leukemia M5 is purely of monoblast and immature monocyte. This is another slide showing acute myelomonocytic leukemia, in which there is the predominant cells here. This is a myelocyte. This is with the monocytic immature monocyte. This is myelocyte. This is myelocyte. This is a monoblast with the you see that there is indentation of the nucleus, this is to be immature monocyte. This is a combination of two types of cells. It is called myelomonocytic leukemia, and as we said, they have characteristic staining with non-specific esterase, lysosomal non-specific esterase, and there is has also some of them showing errors, especially in the myeloid differentiation. This is another AML. This is M5. It is a positive non-specific. This is a positive in the non-specific esterase, showing black to brown dots in the cytoplasm. This is a monoblast with the immature monocytes. Monoblast. This is a monoblast. Look at the blast. Monoblast. It is with the nucleoli in the nucleus, and this is immature monocyte. This is in addition to it be positive with the non-specific esterase stain, it is also positive with the CD68. This is also the peripheral blood film in acute monocytic leukemia. If you see here, there's different stage of myeloid differentiation, including neutrophils, including metamyelocyte. Look at this metamyelocyte. This is a metamyelocyte. This is but the majority of the cells are the monocyte or monoblast. So it is acute monocytic leukemia M5. However, there are more than one stage of differentiation, myeloid differentiation or myelocytic differentiation in this peripheral. This is a monocytic leukemia, and the stain here non-specific esterase. Also, this is a monocytic. This is a non-specific esterase in patient with acute monocytic leukemia M5. This is CD68. Actually, the macrophage or the histiocyte are also stained CD68 in the tissue because they are derived from the monocyte, actually. So the CD68 are positive in patient with the acute monocytic leukemia. This slide showing positive stain of the acute monocytic leukemia with CD68. M6, coming then to the M6, which is acute erythroleukemia, which constitute about 5% of acute mild leukemia. It is most commonly associated with the abundant dysplastic erythroid progenitors, usually occur in advanced age or might follow a chemotherapy. The last one is M7, which is acute megakaryocytic leukemia, which constitute it is considered when it is rare form of the myeloid leukemia. It is constituted about or represent only 1% of them. The blast of megakaryocyte predominate, which is stain positive with a platelet associated antigen. Errors are absent in this type of the leukemia, and it is characterized by the reticulin increase in the reticulin in the bone marrow, called myelofibrosis is common. This is M6 erythroleukemia. If you remember, when in this is the erythroid series, this is a nucleated red blood cell. It is a nucleated RBC or normoblast, which is the precursors of red blood cell, which can be seen a large amount in hemolytic anemia and the shedding of because of the increased production of the blood. Here is the blast form of the immature form of the erythroid. It is very characteristic. Look at the stain of it is more basophilic cytoplasm and coarse chromatin in the round nuclei. This is the blood film in acute erythroid leukemia. The malignant cells are precursors of erythrocyte of red blood cell or erythrocyte. This is a normoblast or erythroblast, called erythroblast, which is this is a nucleoli, coarse chromatin, basophilic cytoplasm. This is a erythroid leukemia, more darker chromatin in the nuclei. M7, which is acute megakaryocytic leukemia, which represent only 1% of the type of AML. This type of this we have more than one megakaryocyte, which are precursors of the platelet. Also, this type of the leukemia that increase in the myelofibrosis also, or increase the reticulin in the bone marrow, which form myelofibrosis. This is megakaryocyte also, leukemia, M7. The malignant cells are precursors of the platelet or thrombocyte. This is a dysplastic, abnormal blast, megakaryoblast, which is the precursors of the thrombocytes, large, giant dysplastic precursors of the platelet. Coming to the histochemistry, the cases with the granulocytic differentiation typically positive for the enzyme myeloperoxidase, which is detected by intubation of the cell with peroxidase substrates. Errors are intensely peroxidase positive, which can help bring out their presence when they are rare. Monocytic differentiation demonstrated by staining with lysosomal non-specific esterase, as we mentioned in the slides. Now coming with the immunophenotype. These are important. Immunophenotype, the karyotype, the stain histochemistry are very important to reach the final diagnosis and the proper diagnosis in order to know the correct the diagnosis of the acute myeloid leukemia, the type of the subtype of the acute myeloid leukemia, in order to give the patient a proper therapy. The expression of immunological marker is heterogeneous in acute myeloid leukemia. Because there are more than one type, there are subtypes, different subtypes of the acute myeloid leukemia. So the immunological marker is heterogeneous, is different. Most express some combination of myeloid-associated antigen, as in the CD13, 14, 15, 64, or CD117. The CD33 is expressed where on pluripotential stem cell, but is retained on myeloid progenitor cells. Monoblast, as we see in the previous lecture, it is positive for 68 antigen. This is very important markers to help the distinguish acute myeloid leukemia and identifying the primitive acute myeloid leukemia, the type M0 or M1, which are minimally differentiated from the other from the acute lymphoblastic leukemia, because instead in the M1 subtype and M1 is really so hard to differentiate it from the acute lymphoblastic leukemia. Therefore, by using immune phenotype and by using the myeloid associated antigen, is the things become more easier and the diagnosis become more readily to be done. In addition, monoclonal antibody reactive with platelet-associated antigen is more helpful in the diagnosis of the M7 subtype, which is acute megakaryocytic leukemia. While chromosomal abnormalities that showing 90% of patients with AML have a chromosomal abnormality. So it is actually a high percentage of the patient with AML that harbor chromosomal abnormalities. Most of them are associated with acquired mutation in transcription factor, which lead to the inhibition of normal myeloid differentiation and lead to the accumulation of the cell at earlier stages of development. According to the type of the AML, maybe accumulation of the promyelocyte, maybe accumulation of the myeloblast, of the monoblast, of the myelomonoblast, according to the type or the subtype of acute myeloid leukemia. There are certain particular interest in 1517 translocation in this type of which is acute promyelocytic leukemia, as we discussed in the previous lecture, previous slides. AML associated with the age 21 and or maybe associated with the inversion of chromosome 16 have favorable prognosis. This type of the translocation or inversion of the chromosome is associated with the good prognosis or better prognosis than others. Whereas those associated with the 922 translocation called Philadelphia chromosome, which is mostly seen in chronic myeloid leukemia, if it is seen this type of seen in acute myeloid leukemia, this carry bad prognosis. Now we are coming to the other types of the leukemia: chronic myeloid leukemia, CML, acute lymphoblastic leukemia, and chronic lymphocytic leukemia. We are starting with the chronic myeloid leukemia, CML. Principally, it affects the adults in between 25 to 6 years of age, and it's account about 15% to 20% of the all cases of leukemia. The peak incidence of this type of the leukemia in 4th and 5th decade of life. The pathophysiology. 95% of CML is uniformly associated with the presence of genetic abnormality in BCR-ABL fusion gene. This is important because the BCR-ABL fusion gene is the product of what? Philadelphia chromosome, which is a translocation in 922 translocation, that when there is a translocation in this chromosome, it moves the ABL gene from the chromosome 9 to be in a position on chromosome 22, adjacent to the BCR gene. The derivative of chromosome 22 is often referred to as Philadelphia chromosome because it was discovered in Philadelphia. So in the patient with chronic myeloid leukemia or CML, the BCR-ABL fusion is present in granulocytes, erythroid, megakaryocyte, B-cell precursor, and some T-cell precursor as well. The chromosomal study of chronic myeloid leukemia showing that Philadelphia chromosome. What is the Philadelphia chromosome? There is a translocation moving of ABL from chromosome number 9 to the chromosome number 22. This is a translocate 922 in a chronic myeloid leukemia, which is called a Philadelphia. This is a chromosomal study which showing T922 with BCR-ABL fusion gene. Normally, this is a chromosome number 9, and this is a normal chromosome number 22. Here, what happened? There is when there is a translocation, when there is Philadelphia chromosome translocation, يصير تبادل 922. Part of the chromosome 9 which is ABL part يسموه ABL وين يروح على chromosome number 22 adjacent to the gene BCR فيسموه BCR ABL, a translocation in between 9 and 22, which is seen in about 90 to 95% of the patient with the CML. So this finding is firm evidence for the origin of the CML from pluripotent stem cell. Normal myeloid progenitors depend on signal which is generated by growth factors and the receptor for growth and survival. But in CML progenitor have much decreased requirement. The altered growth factor dependence is due to the presence of the BCR and ABL fusion gene, which produce protein that simulate tyrosine kinase, which generates signal that mimic the effect of the growth factor activation. So what is the importance of this? The importance of this, the therapeutic point of the view, we can choose the proper drug or the therapy that is like Gleevec, which interfere with that protein. So although the BCR-ABL fusion are present in multiple lineage for unknown reason, granulocytes are most affected. So as evidenced by marked elevating in the number of the granulocyte in the bone marrow and the peripheral blood, the proliferation retain the capacity for the terminal differentiation. The Philadelphia chromosome is highly characteristic of CML. It should be remembers that is present in 25% of the adult with ALL and rare case of the AML. But when it is present in CML, which is in majority of the cases actually, and it is highly characteristic of CML, Philadelphia chromosome, but the patient with CML with translocation have favorable prognosis, but it is also present in other type of the leukemia. So it is highly characteristic, but it is not specific to it because it might be found in about 25% of the cases with acute lymphoblastic leukemia and also in a percentage of the cases in acute myeloid. The morphology. Peripheral blood film finding is highly characteristic in patient with the chronic myeloid leukemia. Because, why? The way it is characteristic. Because the leukocyte count is highly elevated. It's about 100,000 cells per micrometer liter. The circulating cells predominantly are all the type of the granular neutrophil, granulocytic series, neutrophil, metamyelocyte, myelocyte, basophils, eosinophils are prominent. We see all the types of the granulocytic series in the peripheral blood. Small proportion of myeloblasts, less than 5%, might be seen also in the peripheral blood. The increased number of the platelet thrombocytosis is also typical of chronic myeloid leukemia. The bone marrow is hypercellular because of the hyperplasia of the granulocytic and megakaryocytic precursors. Myeloblasts are usually only slightly increased in the bone, not like acute myeloblastic leukemia, in which the high proportion of the bone marrow is occupied by the blast with a different stage of maturation. This is a chronic myeloid leukemia. We can see this in this patient. First of all, the diagnosis depends on we have to do the white blood cell count, which is very high. It's when the white blood cell reaching 100,000 or more than 50,000, we have to take into consideration that the patient might have leukemia. However, white blood cell might be high also in the certain severe infection. So we have to be so precautious in diagnosis of the patient with the chronic myeloid leukemia. And I will proceed now to other diagnostic approach that will definite your diagnosis. Chronic myeloid leukemia, here, peripheral blood, we see all the series of the granulocytic series: mature granulocyte, neutrophil, eosinophil, basophil, myelocyte, metamyelocyte, all of them. This is a metamyelocyte. This is a this is monocyte. This is metamyelocyte. This is a myelocyte. This is all of them are seen in the peripheral blood. Few blast cell might be seen, but generally all the mature granulocytic cells are seen in high percentage or high number in the peripheral blood film. This is the platform in the chronic myeloid leukemia. This is neutrophil, and also, as we said, there is thrombocytosis, increase the number of the. This is a basophil. This is a monocyte, also. This is a neutrophils. This is a myelocyte. Also, other form of the chronic myeloid leukemia. This is a metamyelocyte, band form. This is a band form, actually. Metamyelocyte. This is a band form, which is then become segmented to be neutrophil. This is a myelocyte, the granules, myelocyte. This might be blast. So this is a myelocyte, and this is a neutrophils. This is a band form or metamyelocyte. The clinical feature of the chronic myeloid leukemia, the onset is usually slow, and the initial symptoms are generally non-specific, maybe fatigability, maybe pallor, weakness, weight loss, headache, whatever. But the patient has extreme splenomegaly, which is the characteristic feature of this disease. Splenic infarct is often seen. The red pulp of the enlarged spleen has appearance that resembles bone marrow. Why? Because of the extensive extramedullary hematopoiesis. So the course is one of the slow progression. Even without treatment, the patient median survival is 3 years. Sometimes about 50% of the individual with CML get into an accelerated phase or through the accelerated phase. What is that? Does that mean? There would be a gradual failure in response to treatment. That means there is a relapse of the treatment, and patient develop increasing in anemia, new thrombocytopenia, a relapse. That means there is a relapse. That means the failure to respond to treatment. And at the same time, there is sometimes appearance of additional cytogenetic abnormalities, and patient might have a picture which resemble acute leukemia, which is called a blast crisis. In such a case, we have seen in the bone marrow, of course, more than 20% of the blast. As you know that when we say that acute leukemia or chronic leukemia, acute leukemia means there's a blast in the bone marrow more than 20%. Normally, the blast is less than 5%. More than 20% mean that patient is transformed, or there's transformation into blastic crisis. So we should be so precise and punctual when we diagnose the cases. We have to know the amount of the number of the blast cell in the bone marrow in order to decide whether this is a acute myeloid leukemia or a chronic myeloid leukemia. Sometimes it is necessary to distinguish CML from the leukomoid reaction. What does that mean? In cases of infection, of stress, of abscess, of neoplasm, there would be dramatic elevation, profound elevation of the white blood cell, granulocyte count. So how could we differentiate this? Why don't we say that it is a chronic myeloid leukemia? Of course, this is something confusing to us as a pathologist and hematopathologist, and also to the physician, especially if the count of the white blood cell become very high, maybe 50,000, very high. It is in general, it is very high, whatever. We have to do, it is called leukomoid reaction in case this case is not leukemia. How could we differentiate such a case from the chronic myeloid leukemia? At first, the presence of Philadelphia chromosome is very important, which is definitive way of distinguish CML from the leukomoid reaction. As you know, more than 90%, about 95% of CML has patients has Philadelphia chromosome, which is very easy to let us distinguish in between two. At the same time, there is a certain measuring of the alkaline leukocyte alkaline phosphatase. In the leukocyte alkaline phosphatase, it is very helpful procedure because the granulocyte in the CML are almost completely devoid of this enzyme. No alkaline phosphatase should be seen in granulocyte of CML, while in the it is increase in leukomoid reaction and other myeloproliferative disease as in the polycythemia vera. So these two way we can use and perform to reach the proper diagnosis and to distinguish two conditions. Now we are starting with acute lymphoblastic leukemia. Actually, this type of leukemia is one of the most severe aggressive type that develop in the young age group, actually in the kids. A malignant proliferation of immature pre-B or pre-T lymphocyte, which referred as a lymphoblast, is highly aggressive tumors that present with the symptoms of the bone marrow failure. What does that mean, bone marrow failure? Mean that patient have severe anemia, patient have thrombocytopenia, patient have severe infection, high fever, unresolving fever, POO, pyrexia of unknown origin. One of the presentation of the patient that the fever exceeding 38 and does not resolve or get down by the by any medication. At the same time, it take a longer time than the usual or the ordinary infection. Or it is due to the rapidly growing masses, as therefore the patient might present with a severe bone pain and severe tenderness. The tumor cells contain genetic lesions which block differentiation. It is differentiation into the lymphocyte in this lymphoblast. So the tumor, the predominant tumor cell in the bone marrow is the lymphoblast, which is immature blast, which of course that's non-functioning or as immune cell. This is account for the major clinical manifestation or the presentation of acute clinical feature of patient with acute lymphoblastic leukemia. As I mentioned, that most of the acute lymphoblastic leukemia occur and take place in individuals younger than 15 years of age, younger age group. In the children, more commonly in the children, more common and frequent in the boy than girls. Peak incidence is 4 years of age, so it is very small kid. It is so any kid with a very small age, 4 years, 5 years, 6 years, above the, anyway, less than 15, when he has high fever, very high fever, unresolving fever, PO paroxysm of unknown origin. There is no focus of infection. Patient have severe tenderness and bone pain. Have all the headache, severe fatigue all over the body. We have to think and exclude the acute lymphoblastic leukemia. It does occur in the adult? Yes, it does occur, but less frequently. 84% of the ALL are pre-B cell, because you know that ALL might be pre-T or pre-B, but most of them are pre-B tumors, which manifested as a childhood acute leukemia with extensive bone marrow and peripheral blood involvement. What does that mean? That is extensive bone marrow. When we do bone marrow aspirate, there's predominant the bone marrow is predominantly involved by the immature blast cell, and the peripheral blood involvement also. Most of the cells in the peripheral blood showing lymphoblast. Less frequent is a pre-T ALL. If you remember, when the pre-T ALL tend to present in the adolescent, more common in the male as a lymphoma with thymic involvement. The presentation in such patient is thymic mass or thymic involvement in about 50 to 70% of their cases. May be presented with the lymphadenopathy, hepatosplenomegaly, shortness of breath, mass in the superior anterior mediastinum. All these the presentation of the pre-T acute lymphoblastic leukemia, in addition to the systemic manifestation of the leukemia, which is including fever, fatigue, loss of weight, anorexia, loss of appetite, all of these. There is stormy onset of symptoms. What does that mean, stormy? It's acute onset of the symptoms, and it's severe associated with severe symptoms. It include, as I told you, fatigue because of the anemia, fever, which reflecting infection, which result from absence of mature leukocyte. Instead, the patient have lymphoblast in the blood form. Bleeding tendency, patient might present with a petechiae, diathesis, bleeding diathesis, such as epistaxis, ecchymosis, bleeding per gum or gamma bleeding, because of due to the thrombocytopenia. Bone pain and tenderness, which result from the bone expansion and infiltration of subperiosteum. Lymphadenopathy, splenomegaly, and hepatomegaly also caused by dissemination of the leukemic cell in these organs. Central nervous system manifestation of the acute lymphoblastic leukemia, including headache, severe headache, vomiting, nerve palsies resulting from the meningeal irritation. Testicular involvement are common in patients with acute lymphoblastic leukemia. Those features are more common in the children than in the adult, and are more common in ALL than acute myeloid leukemia. Morphology. Both subtypes of acute lymphoblastic leukemia, pre-T and pre-B cell, have the same morphological pattern, actually. Basically, they look like this, the same. They mimic each other. Lymphoblasts have scant agranular cytoplasm with large nucleus showing delicate, finely stippled or coarse chromatin, and absence or inconspicuous nucleoli. This is, of course, different from the AML that have more finer of the chromatin and have prominent numerous nucleoli and more abundant cytoplasm. In some cases, the nuclear membrane showing convoluted or lobulated appearance. This is seen in ALL. The cytoplasm, in you remember in AML, you have all when you study the slides and when you read them, you have to correlate each slide with the another one in order to solidify the information. If we remember in AML, which is the positive stain in the cytoplasm, it is peroxidase or myeloperoxidase. What is here positive in ALL? It is in PAS stain, unlike the peroxidase, which is positive in myeloblast. So we are coming here. Look at this. This is typical of acute lymphoblastic leukemia in the bone marrow. Look at the nucleus, large nucleus. Some of the nucleus are convoluted, but here we have seen there is no convoluted. This is the fine, the smooth outer nuclear membrane is smooth, but the chromatin is coarse chromatin, darker chromatin, inconspicuous nucleoli. It's difficult or hard to be seen, not like the nucleoli that is seen in the AML. So, the rim of cytoplasm, there is narrow rim, very scanty cytoplasm here in the acute lymphoblastic leukemia. This is sheets of the immature blast in the bone marrow. This is a blood film in patient with acute lymphoblastic leukemia. Look at the cell. This is abnormal cell that is found in it is not the lymphocyte, it is the cell that are larger than lymphocyte. Look at it, it's atypical cells with a coarse chromatin, stippled chromatin. It is uneven chromatin distribution in the nucleus with a scanty cytoplasm. The nucleoli are, there is a nucleoli, but are very inconspicuous or very small. This is a peripheral blood film in patient with acute lymphoblastic. The immunostain that are used in the patient with the acute lymphoblastic leukemia. We use the TDT, terminal deoxytransferase, which is a specialized DNA polymerase which expressed only by pre-T or by pre-B lymphoblasts, which is positive in the 95% of the cases. This is very good way or very good method in order to reach that definite diagnosis of the acute lymphoblastic leukemia. We can stain the cells if we are doubt that whether this type of leukemia is ALL or AML. There are many staining methods that can confirm our diagnosis and exclude the other differential. So TDT is one of the important methods to be used in order to be, and it is expressed and to be positive in patient with the pre-T or pre-B lymphoblast in about 95% of the cases. Subtyping of the ALL into pre-B or pre-T is rely on stain of lineage specific, such as CD19, which is B cell, or CD3, or CD5, which is in the T cell. This is another in order to when we reach the diagnosis that this is a pre-B or a pre-T acute lymphoblastic leukemia by using this TDT, we have to subtype whether it is T, whether this B, because it is different in the prognosis. We can stain the lineage by specific markers, CD19 for the B cell and CD3 for the T cell. This is a figure which showing that TDT, terminal deoxynucleotide transferase in lymphoblastic lymphoma. TDT, it is in the nuclear. This is a nuclear staining of the TDT in acute lymphoblastic leukemia. The karyotypic changes. Basically, about 90% of the patients with lymphoblastic leukemia or lymphoma have non-random karyotypic abnormalities. Most common in pre-B cell tumors is hyperdiploidy, more than 50 chromosomes per cell, which is associated with the presence of the cryptic 12-21 chromosome translocation involving EL1 and AML1 gene. The presence of this aberration correlates with good outcome. Poor outcome are observed, or poor prognosis are seen in patients with a pre-B cell tumor that have a translocation involving the gene on chromosome 11, this is carry bad prognosis, or Philadelphia chromosome translocation between 9 and 22. This is carry bad poor prognosis in patient with ALL. With aggressive chemotherapy and prophylactic treatment of CNS, more than 90% of children with ALL achieve complete remission, and about 2/3 of them are cured. There are certain factors that are associated with poor prognosis, include very young age, less than 2 years, the presentation in adolescent or adulthood, and the presence of translocation between 9 and 22 Philadelphia chromosome, which is seen about 3% of ALL and 25% of adulthood, 3% of childhood ALL, while 25% of adulthood. In such a case, bone marrow transplantation offers a hope for those with poor prognosis. Now we are coming to the other type of the leukemia, which is in contrast to the acute lymphoblastic leukemia. It is more commonly and frequently occurs in the elderly age. So it is a chronic lymphocytic leukemia, CLL. It is the most common leukemia in the adult. This type of leukemia is indistinguishable from the small cell lymphoma only by the involvement of the peripheral blood film or the blood involvement, peripheral blood involvement. If it is involved peripheral blood, so it is CLL. If it is only confined to the lymph node, so it is a small cell lymphoma. Peripheral blood film contain mature lymphocyte, large number of small mature lymphocyte with a scant cytoplasm. Those cells are so fragile and disrupted during the preparation that appear in the blood smear as smudge cells مسحوقة كأنه خلايا مسحوقة كأنه, because they are so fragile and they are very large number. So when during preparation of the blood film, it appears as smudge cells. Total leukocyte count may reach 200,000 cells per cubic millimeter. This type of the leukemia, actually, it is one of the indolent types of the leukemia. That to say, the patient might come to the physician or to the laboratory just for the routine checkup. And then we found that he has very large number of the white blood cell. When the differentiation of the white blood cell differentiation is appear that it is small lymphocyte. So this patient, mainly the diagnosis depend on the peripheral blood film. When we found that there are large number, 200,000 cells per cubic millimeter, we diagnose, and smudge cells, we diagnose that the patient have small chronic lymphocytic leukemia. In such a patient, we just follow up the patient. We don't do anymore because the patient first elderly and the course of this disease is indolent only unless the patient develop a crisis or a plastic transformation, pro-lymphocytic transformation, in which more the transform into the more aggressive course. In such a case, we will treat the patient according to the situation that he will develop later. Bone marrow involvement is seen in all cases of CLL taking the form of interstitial aggregate of small lymphocytes. Splenic involvement showing both red and white pulps enlargement caused by the leukemic cell infiltration. Hepatic portal tracts are also infiltrated by the leukemic cell. The leukemic cell express pan-B cell markers such as CD10, CD20, T cell marker CD5. It expresses both pan-B cell markers 10 and 20 and T cell marker CD5. This is interstitial or paratrabecular involvement of the bone marrow. So paratrabecular mononuclear lymphocytic, look at it. It's highly cellular bone marrow, and it is involvement by the mature small lymphocyte. It is in chronic lymphocytic leukemia, paratrabecular mononuclear cell involvement in the bone marrow biopsy. This is the smudge cells. Look at it. This is a smudge cells in which there is just this, because they are so fragile. So during the preparation, it will be become smudged. This is a blood film in patient with a chronic lymphocytic leukemia. Look at it. These are small mature lymphocytes in the blood film. When the patient with a chronic lymphocytic leukemia develop a pro-lymphocytic transformation, what will happen to the patient? What does that mean, pro-lymphocytic transformation? It occurs in about 15 to 30% of the patient with CLL. The pro-lymphocytic transformation is characterized by the appearance of the pro-lymphocyte in the peripheral blood, more immature cells that develop and appeared in the peripheral blood. Those cells have large nucleus and central place nucleolus, or the transformation into the diffuse large B-cell lymphoma, which occurs in 10% of the cases, called Richter's syndrome. This transformation have a very bad prognosis and carry very progressive deteriorating course, and most patients survive less than 1 year. So in pro-lymphocytic leukemia, when there is transformation into the pro-lymphocyte, in this type of leukemia, the cancer are a lot like normal, like pro-lymphocyte, as we said. They are immature form of B, pro-lymphocytic leukemia, or T, and tend to grow more faster and spread than the usual type of the chronic lymphocytic leukemia, in which the course is slowly and relatively indolent. However, most of the people respond to some form of the treatment, but there are attacks or they tend to relapse and the cancer come back. The pro-lymphocytic leukemia, which develop in patient with that has already chronic lymphocytic lymphoma or small lymphocytic chronic lymphocytic leukemia or small lymphocytic lymphoma, in which case that tend to be more aggressive, but it can also occur in people that they don't have or never have chronic lymphocytic leukemia. It might arise in patient with no history of the chronic lymphocytic leukemia, and the course would be more aggressive than, as we said, chronic lymphocytic leukemia. Clinically, the patient with CLL most commonly are over 50 years, male more common than female, about 2 to 1, usually asymptomatic. The symptoms when present include just weight loss, fatigability, anorexia. Otherwise, it is asymptomatic. Patient might be presented with CLL, as I told you, by routine checkup. And according to my experience, there are many patients that diagnosed CLL by the blood film just when they are coming to the laboratory and diagnose they have CLL by the peripheral blood film. Patient might have generalized lymphadenopathy, enlargement of the lymph node in the cervical region, in the axillary region, or inguinal, or hepatosplenomegaly. Might be seen in about 50 to 60% of the cases. In about 10 to 15% of the cases have autoantibody to the red blood cell. Therefore, those patients with against the red blood cell and platelet. Therefore, those patients with a chronic lymphocytic leukemia sometimes have autoimmune hemolytic anemia. So one of the causes of the autoimmune hemolytic anemia and thrombocytopenia is chronic lymphocytic leukemia or lymphoma, because it might be associated with production of autoantibody in about 10 to 15% of the cases. Prognosis is extremely variable overall, 4 to 6 years, but some cases may live for 10 years unless it's developed prolymphocytic transformation or Richter syndrome. Now we are starting with a new topic or the new type or the other type of leukemia, which is hairy cell leukemia, HCL. Hairy cell leukemia, it is rare cancer of the lymphocyte that tend to progress slowly. This type of the cancer cell are type B lymphocyte, but they are different from those seen in CLL. There are also important differences in symptoms and treatment. Hairy cell leukemia gets its name from the way the cells look under the microscope, because there is fine projections, hair-like, on the surface of the cell. Treatment of it can work very well. It affects and occurs more frequently in the male than in the female, and more common in the middle-aged or older adult. This is a hairy cell leukemia. Look at the B cell, abnormal looking. Under the light microscope, there is a radial projection from their surface. If you focus very well on this slide, you will see that this is the hair projection, which is radial projection, which is seen from the surface of this abnormal looking lymphocyte. Actually look like hair. Therefore, it goes its name from this characteristic feature of their cells. Hairy cell leukemia considered a chronic disease because it may never completely disappear, although the treatment might followed by remission for years. Sometimes the clinical symptom of the patient, there's no sign or symptoms, but when they do blood test for another disease or just for checkup, they reveal hairy cell leukemia. Other time, people with hairy cell leukemia experience signs and symptoms common to a number of diseases and conditions. Feeling of fullness in the abdomen, that may feel uncomfortable to eat, fatigue, bruising, recurring infection, weakness, weight loss. Actually, the hairy cell leukemia considered one of the causes of the massive splenomegaly. Therefore, the feeling of the fullness of the abdomen might arise from this characteristic. The complication. As this type of leukemia progresses very slowly, and sometimes the patient remains stable for life, but there are certain complications that might occur during this illness. especially if the patient is untreated. The hairy cell leukemia that progress may crowd out the healthy blood cells in the bone marrow, crowd them, which lead to serious complications such as infection, bleeding, anemia. Infection because it reduces the healthy white blood cell, so put the patient at risk of the infection that the body might otherwise fight off. Or bleeding because the low platelet count make it hard for the body to stop bleeding once it starts. So if there is mild low platelet count, the patient might notice that they have bruise easily, but sometimes very low platelet count might lead to spontaneous bleeding that from the gum, from the nose, that cannot be stopped once it starts. Anemia also, when red blood cell count mean that few red blood cells are available, which is important to carry the oxygen. Therefore, this is called anemia, and the anemia might lead to feeling of the fatigue and pallor and tiredness. On physical examination, about 80 to 90% of the patient have enlarged spleen, which can be massive, which is so we already mentioned that one of the causes of the massive splenomegaly is hairy cell leukemia. Peripheral lymphadenopathy, enlargement of the lymph node, is uncommon. It's about less than 5% of the patient, but abdominal lymphadenopathy is common by CT scan exam. The most common important lab finding is the presence of the hairy cell in the bloodstream. When the lymphocyte with radial hairy projections, as we see in the peripheral blood count in the bloodstream. These hairy cells are abnormal white blood cells with hair-like projection of cytoplasm. They can be seen in the peripheral blood smear or in the bone marrow biopsy specimen. The blood film examination is done by staining of the blood with Wright stain and looking at them under a microscope. The hairy cells are seen and visible in this test in about 85% of the cases. Now we are coming to the new topic that I add to these lectures, which you should know about it because you almost will hear about this syndrome. It is myelodysplastic syndrome, MDS. It is a group of the cancer in which immature blood cells in the bone marrow do not mature and therefore do not become healthy or normal blood cells. Early on, typically there is no symptoms. The patient might asymptomatic, might be discovered when he do routine blood checkup or blood work. But later, the symptoms may include a feeling of tiredness, shortness of breath, repeated infections, bleeding tendency. Sometimes might develop into the acute myeloid leukemia. The types of the MDS, there are many types of the MDS, including refractory anemia with the ring sideroblast, and there are many types actually of the myelodysplastic syndrome, depend on the specific changes in the blood cell and the bone marrow. The risk factors of the myelodysplastic syndrome include the age, which is more common in the adult age group, those patients with receiving the previous chemotherapy or radiotherapy or exposed to the certain chemicals such as tobacco, benzene, pesticides, smoke, mercury, lead. Problem with the blood cell formation result in low red blood cells and low platelet. Patient has anemia, thrombocytopenia, and neutropenia. Sometimes some of the some types of the myelodysplastic syndrome has increasing the immature blood cell called the blast in the bone marrow or blood. Actually, there are about um, five types of the myelodysplastic syndrome. First is refractory anemia, second refractory anemia with the ring sideroblasts, then refractory anemia with the blast. With then the blast is less than 19% of the blast in the bone marrow, because if it is more than 19%, it become acute myeloid leukemia. You have to focus on this point. One of you might ask me why, if it is there is a blast in the bone marrow, why we don't name this, or we don't consider this myelodysplastic syndrome as an leukemia, because when the blast cell is about 5 to 19% of the blast in the bone marrow, it is considered myelodysplastic syndrome, not considered acute myeloid leukemia. As soon as the blast become more than 20% in the bone marrow, so we consider this as a leukemia, acute leukemia actually. The last one, the last type is a chronic myelomonocytic leukemia and chronic myeloid leukemia. So according to the French, American, British classification, they classified the myelodysplastic syndrome into five categories. First is refractory anemia, which is characterized by less than 5% of primitive blood cells myeloblasts in the bone marrow, and the pathological abnormalities mainly in red blood cell precursors. Refractory anemia with ring sideroblast, I will show you slide of it in the last slide of this set, characterized by less than 5% of myeloblasts, but it is distinguished by the presence of 15% or greater of red blood cell precursors, which is iron stuffed cell. It is called ringed sideroblast. There is also other type, third type, ring refractory anemia with the excess of the blast about 5 to 19%. Because if it's more than 19%, as in refractory anemia with excess blast transformation, this is more found that it might defined as acute myeloid leukemia. So it is actually the number or the percentage of the blast in the bone marrow is very important, and it is the cut-off point to differentiate whether this is myelodysplastic syndrome with excess blast or the myelodysplastic syndrome that might be might lead to the acute myeloid leukemia, or it is acute myeloid leukemia when there is more than 20% of the blast in the bone marrow. So these are should be considered very well by the hematopathologist. The five category of or the classification of this is by chronic myelomonocytic leukemia. The sign of and symptoms of the patient with the myelodysplastic syndrome, as we know that it is any refractory and it is anemia, infection because of neutropenia, and thrombocytopenia. Of course, it depends on the which lineage are affected by this dysplastic changes. Some of the individual just have anemia. Some of the individual start on as a symptomatic, there is no symptom, but later on they develop tiredness, pallor, fatigability, weakness. Patient might have splenomegaly or hepatomegaly when examination. By examination of the blood and by the bone marrow, the cells showing abnormal granules, abnormal nuclear shape, dysplastic changes. There is sometimes a chromosomal abnormality, chromosomal translocation also. The diagnosis depends on certain factors, actually. First of all, the elimination of the other cause of cytopenia, as we have anemia, thrombocytopenia, and neutropenia. So we have to exclude As example, aplastic anemia, we have to exclude other factors like vitamin B12 deficiency, folate, other autoimmune disease as in the lupus erythematosus, hepatitis, kidney failure, all hemolytic anemia, all of these should be eliminated and excluded in order to reach the proper diagnosis of the myelodysplastic syndrome. By hematopathologists, the bone marrow examination is very important and required to confirm the diagnosis. Also, other tests such as cytogenetic or chromosomal study, virtual karyotyping, flow cytometry, all of these measures should be done for the patient to reach the proper diagnosis. The goal of therapy, the patient in myelodysplastic syndrome. The goal depends on the controlling of the symptoms, improving the quality of life, the style of the life for those patients to improve the overall survival and decrease progression to acute myeloid leukemia. Because one of the outcome of the myelodysplastic syndrome, it might lead to the acute myeloid leukemia, especially if the blast percentage of the blast become more than 20%. So, supportive care, drug therapy, and stem cell transplantation are the treatment of choice for such patient. Supportive treatment and including blood transfusion, medication to increase the making the red blood cells, antibiotic, and all other mode of treatment that should be taken into consideration to treat such. Here it is the bone marrow aspirate therapy in patient with therapy-related myelodysplastic syndrome, patient blood smear from adult female with myelodysplastic syndrome related to chemotherapy or radiotherapy for Hodgkin disease. We can see here this plastic neutrophil with a pseudo-Pilger hut nucleus. It's called like bilobed nucleus, composed of two nuclear masses connected with a thin filament of chromatin. This is a bilobed nucleus of the neutrophil in myelodysplastic syndrome. Red blood cells also show marked poikilocytosis and in part related to the splenectomy status, right Gimza stain. The last slide in this set of the slides is a bone marrow aspirate which showing ring sideroblast in one of the type of the myelodysplastic syndrome, which is called refractory anemia with ring sideroblast. Look at it. This is immature red blood cell, but there is ring sideroblast, which occupy about 15% or constitute about 15% or more of these ring sideroblast among the erythroid precursors. What are the ring sideroblasts? They are nucleated erythroblasts, precursor to mature red blood cell, but they are found in the bone marrow, should not be found in the peripheral blood. It's accumulated in the mitochondria and surrounded the nucleus. This is also one of the types of the myelodysplastic syndrome.